We are live. Happy Friday. Hello, Airway Circle. Hello, everybody. We are here with the wonderful Dr. Dania Tamimi. Can you believe that? Welcome, Dr. Dania.
Hey, thanks. Thanks for inviting me to speak to you
Of
guys.
course. So I'm going to go ahead and introduce Dr. Dania. She graduated with a dental degree from King Saud University in Saudi Arabia. She trained at Harvard School of Dental Medicine and earned a doctorate of medical science and certificate of fellowship in oral and maxillofacial radiology in 2005. She is board certified by the American Board of Oral and Maxillofacial Radiology. She's a reviewer and an editorial board member for oral surgery, oral pathology, oral medicine, and oral radiology, as well as a reviewer for DMFR, oral radiology, head and neck, angle orthodontist, and AJO-DO. She is the lead author of 2 textbooks, Specialty Imaging Dental Implants and Specialty Imaging Temporomandibular Joint, and a co-lead author on Diagnostic Imaging Oral and Maxillofacial. She lectures nationally and internationally. She currently runs her oral and maxillofacial radiology private practice in Orlando, Florida. So let's start with first we have our topic, the use of radiographic imaging for the evaluation of the craniofacial complex. But before we even start, would you tell us a little bit about yourself, please?
All right. Well, I'm in Orlando, Florida, 15 minutes from Disney World. Come and visit anytime,
Yeah.
That isn't too far from where you are, I think, right?
You got to be careful offering that, though.
Right.
We'll take you up on it.
I know, right? Yeah. Well, I'm, as you mentioned, I'm a dentist. Okay, so I'm a dentist and I'm trained as an oral and maxillofacial radiologist. But at the same time, I was training for, I was doing my dental studies, and I was training to be a radiologist. I also had a parallel career in fitness. So basically, I was a fitness instructor, a group exercise instructor, a personal trainer, Pilates instructor, yoga instructor, spinning, whatever was in fashion at that time, I did it, urban rebounding. I don't know if you remember that, the little thing on the trampolines. Yes. So anyway, so I had, I had this passion and this interest in the human body as a whole, like how it works, because you have to know that kind of stuff, like what muscles do what and that sort of thing, and how to work this muscle, that muscle, how to work things in conjunction and that kind of thing. So, and I was pretty good at it too. I was, at the time, I was going through my residency. I was teaching 10 classes a week in addition to doing, that. I wasn't married. I didn't have kids. I had all the time in the world to do whatever I wanted to. So by the time I finished this, I came to a crossroads, and I was pregnant too with my first child. So I came to a crossroads. Where do I go? I was very passionate about this. I had highly qualified, or highly trained in that, so what do I do? And I guess the dentistry trumped it, because it was, you spend a lot more time, I guess, and a lot more dineros in that education, right? So anyway, so I decided, that I was going to just invest my time and effort in that, because I was, I was starting to pop out babies, and through the gestation and lactation and all that stuff that goes along with popping out babies, it was really difficult to maintain both these worlds. Well, anyway, fast forward a few years, I never thought I could ever bring these two worlds together. But then I met my friend and mentor, David Hatcher, who is an oral and maxillofacial radiologist in Sacramento. And don't you just love technology, where someone can be on one end of the country and the other can be on the other end of the country and still be able to communicate, like on a daily basis kind of thing, So he mentored me in the understanding of the TMJ and Airway and that kind of thing. And that kind of set the stage for a more comprehensive evaluation of the radiographic information that's on the scan, or whatever imaging technique is presented to us. Because you'd look at it, normally what a radiologist does is he or she goes through the scan to make sure there's no pathology. And, the pathology can be anywhere, TMJs included, but rarely do you find someone who looks at the scan comprehensively to try to figure out what's happening with this patient's, face, what's happening with this patient's morphology and that kind of thing. So couple that with my interest, like I said, in human biomechanics, my interest in fascia, just that understanding of how things work. I guess the way that I approach scans now is more like that. I'm looking at the whole body rather, or the whole, whatever I have on the scan. I don't have the whole body, but I have it up to here, and I can kind of extrapolate what's happening. Because like these scans are like, and I'm talking now, probably now more into what I'm doing. I'm just going to let this be fluid, let this be.
That's exactly what this is.
It's interesting because, these bones, they tell stories, they're like each bone has, its ability to model and remodel and respond to the environment that surrounds it and all that. Mm-hmm. So when you look at a scan, when you look at a cone beam CT scan, for example, or a panoramic or whatever, that's what you're looking at. What you're trying to tune into is the story the bone is telling you. Mm-hmm. Why does this person look like this kind of thing? So anyway, so this is where I am right now. I don't know where I'll be in like 5-10 years, but currently this is the direction that I'm taking. I'm interested in muscles because obviously, come on, girls.
Exactly.
But that background, but I'm also interested in how the muscles manifest as morphology, craniofacial morphology, changing the bones, that sort of thing.
Definitely. Some people forget that muscles are attached to bone, and I mean, it's all one thing. We're all one person, so you can't just go to a physical therapist and not go, or just go to a chiropractor and not go to a physical therapist. Also, if you'd like the best results for whatever you're dealing with, you need to work on the skeletal structure and the muscle together. Same thing if you go get orthodontics, not addressing the muscle. If there's muscle dysfunction with a myofunctional therapist, you might not get the results long term that you're looking for. So that is a perfect point. We do got to look at both always.
Mm-hmm. Especially in cases of orthodontic surgery and stuff like that, where they're actually creating controlled trauma. They're changing the alignment, and obviously they're changing the position of the attachments of the bones, of the muscles to the bone, not the actual like attachment, but now it's stretched or retracted or whatever it is. So I mean that's kind of like what I try to teach, even though they think they're getting a radiology lesson, but they're getting a lot more.
Yes. So is there any way we can avoid, or how can we prevent more patients from going in that direction, ending up with orthodontic surgery?
Diagnosis. I mean, I guess you have to diagnose your patient early, because I mean, once the patient has gone through a growth deficit and the bones have already modeled to a form that is, you can't bring the teeth into a beautiful class 1 relationship if the jaws are set back or whatever. You have to figure out what's predisposing to this morphology, and hopefully you can catch it earlier and earlier so that it doesn't manifest as that morphology that we see in the dolichofacial, more convex facial profile people who have, for example, juvenile idiopathic arthritis or idiopathic condylar resorption or anything like that.
Perfect. How do you use a CBCT for the evaluation of sleep disorder breathing risk factors?
Oh, okay. So it goes back to looking at the whole patient. All right. So when you think of sleep disordered breathing and the airway analyses on cone beam CT, you're probably thinking of those colorful volumetric measurements, and you're saying, oh, it's narrow, so the patient has sleep disordered breathing, blah, blah, high risk, whatever. Well, I'm here to tell you, no, it's not about that. It's not about this number. I mean, as dentists, we're obsessed with numbers. I don't know how many dentists are out there, but I think everybody here, I mean, anyone who is a dentist will understand the importance of a 1 millimeter clearance or a 2 millimeters clearance, you know, when you're cutting a crown. I mean, really, we're really obsessed down to the micromillimeter, you know, sometimes in our dental procedures, that we forget that sometimes the body doesn't play with those rules, you know. So these measurements without the clinical correlation don't really mean much, because you can have a really nice wide airway on cone beam CT, but you know, the patient would have, you know, sleep disordered breathing or sleep apnea or whatever, and you can have a small airway and not have any symptoms. It's not about the dimensions; it's about muscle tone, you know, morphology of the rest of the craniofacial complex, as well as, you know, the fact that when you're scanning people, they're upright and awake. I mean, most cone beam CT scanners are in the seated or standing position. Who sleeps standing up? Are you a giraffe or a horse or something like that? No, you're not, you know. We don't sleep standing up. We don't sleep sitting up either. You know, we're supine or prone or something like that. And also when we lose consciousness, we lose the ability to hold that airway patent. So the airway dimensions that you capture on your cone beam CT do not correspond to what's happening when this person is asleep. You know, really, what you're looking for on cone beam CT are those risk factors for sleep disordered breathing. What in the morphology of the patient's face can predispose them to the inability to draw the breath in properly when they sleep, such as a narrow nasal cavity, and there are different components of the nasal cavity that can be evaluated. Narrowing of the nasopharynx due to the presence of large adenoids, you know, narrowing of the oropharynx due to a multitude of reasons, palatine tonsils being one of them, a long, thick, soft palate being another, a large tongue being another, fat deposits. I mean, when you're, you know, any woman over the age of 40 knows that when you lose weight first in your face and your neck, you know, and you start looking all wrinkly and all that, right? So and that's one of the first places where the fat is deposited also when you gain weight. So a good thing to tell people is to try to lose weight, to try to minimize those fat deposits in the parapharyngeal area, in order to help increase airway dimensions, you know. So there's like a diet, nutritional advice that goes into this as well. So what else? I went off on a tangent. The face itself, you know, the jaws, you know, the shape of the jaws, the morphology of the jaws, the size of the jaws, you know, the alignment of the teeth, that kind of thing. The TMJs and their integrity and their form and function or dysfunction. All these things are things that one would look for when you're looking at a sleep disordered breathing patient, you know. I mean, in addition to multiple other things, but, you know, that's just like skimming it right here. So anyway.
Definitely. Somebody said, yes, thank you. Volumetrics can be misleading both ways. It's how we create, utilize, and maintain space in planes of posture and movement.
Absolutely. Absolutely. And you can train that. I mean, just like you train your biceps, you know. I think I'm preaching to the choir here, you know that you can train these muscles, right? So,
Definitely, but we like to hear it.
Yeah, I'm sure you do.
Anyways, guys, if you're watching this, please hit the like button or the little heart and share this with your friends so we can reach more people. I know that a lot of people are working right now. Dr. Martha sent me a message asking, how can I get in? So hopefully more people are going to join, but this is going to be recorded and you can watch it later also. Let's go to our next question. What do you think of the airway volume dimensions that we get off of Cbct images?
I just mentioned that. I think it's okay. I really honestly think that cone beam CT manufacturers use it to sell machines. All right. It's a good visual tool to tell the patient when the patient does have small airway, you know. Hey, look, this is what your airway looks like. Let's look at it in 3 dimensions, that kind of thing, you know. But it's not the central thing that you should be looking at. Once again, you need to be looking at everything, how the face is. I mean, one of the first things that I do when I open up a scan is I create a 3D surface rendering and 3D rendering basically of the face, and I look at it frontally and I look at it laterally. Do I see a narrowness, a general narrowness in the formation of the face? You know, do I see a more convex facial profile, a retruded mandible? What do I notice about the head posture? I know that, you know, in a cone beam CT unit, you basically have to put the patient in whatever the positioning device. So the head posture might not be 100% to what the patient's natural head posture is, but when you do put the patient in that position, if, for example, you put the chin on the chin rest and the head's forward and the airway is still small, that's telling you something, right? So if the patient is in natural head posture and they've got this forward head posture, that is also telling you something. Either they're spending too much time on their iPad, or they're, you know, they have their head forward for a reason, and that is to increase airway dimensions, you know. So, I mean, we can do something right now if you'd like. Just I want to show you how malleable this tube is. You know, let's just like sit up, like put your feet on the ground, everybody. I don't know if everybody here's, you know, sitting or standing or whatever. Just get into a comfortable upright position. Take a deep breath in through your nose, you know, in and out. Just notice where your breath is, you know, and how it feels as it enters and exits through your body. Through your nose, please. Keep the lips sealed. All right, and then just move your head forward and notice the change in volume. And then
so much
so much more, yes. And then try moving your head back, you know, just tuck your chin like that. You know, don't tilt your head up, just move it back and just notice how much more restricted it becomes, okay? So, yeah, so one of the protective mechanisms that human beings have to increase airway dimensions is to move their heads forward to increase the patency of the oropharynx, okay? And a child with large palatine tonsils, a child, you know, with small airway for whatever reason, will do that habitually without anyone telling him to, because that's just the nature, what nature gave him or her to protect themselves from dying. You know, they need to breathe. So, and that's just one of the protective mechanisms. But with that forward head posture comes a remodeling of the entire skeleton, because when you move your head forward, then you're changing the alignment of your cervical spine, you know, and there's a compression of the spinous processes when you're in a hyperlordosis situation. You know, you can have degenerative joint disease occurring over time, you know, with the myofascial imbalances going on with that. So tightening of the back of the neck, loosening of the neck muscles in the front, the suprahyoid and infrahyoid muscles. In addition to the rest of the body, because like your head doesn't exist by itself, you know, your head and your cervical spine are not floating there by themselves. They're connected to the rest of the body. So if you have a hyperlordosis or forward head posture also, then the rest of your body is going to remodel in order to accommodate for that shift of the weight of the head forward. So your center of gravity needs to change, you know, because like your head's forward, now your center of gravity is forward. So what's going to end up happening, I'm just going to stand up for a second to show you. Actually, let me pull up my hair.
The snowball effect.
Yeah, I mean, there's always cause and effect of the body. I mean, the simplest thing, like, what can I say? Let's say you always cross your legs. You know, if you always cross your legs, then you're going to be tight on one side, and then there's going to be a change in the alignment of your cervical spine. You might have a slight scoliosis. But let me show you with this kind of thing. So I don't know if you can see my entire body. Let's go like that so you can see. Okay. All right. So neutral. This is neutral. Can you see? Yeah. I think you can see pretty much everything I want you to see. The cervical spine, the thoracic spine and lumbar spine. Okay, so I'm neutral here, right? But if I have my head forward, now my center of gravity changes. So the rest of my body has to remodel in order to accommodate for that. All right, so So I have now hyperlordosis of the cervical spine, hyperkyphosis of the thoracic spine, and excess lordosis here. And that doesn't feel too good for me because I like to keep my spine in relative neutrality.
I can just stand up and show you what it looks like because I have all of it.
Go ahead.
Kyphosis, lordosis, and scoliosis.
And part of it is, I mean, I'm not saying that everybody who has this morphology is a sleep disordered breathing patient. It's just, you know, that's just the human biomechanics. That's how we function. That's how our body changes. Because our bodies also tell a story. You know, it's not just the bones that are telling a story. Everything that your body does tells a story. You know.
I love that.
So another nice example.
I love that. You can keep going.
Yeah. Are you right-handed or left-handed?
Right-handed.
Okay, so I just like sit at your desk right now and just notice. Grab a pen and notice what happens to your torso as you write. Okay, do you stay straight, or is there a little bit of a rotation that happens? Your shoulder.
It goes this way.
Right. So if somebody finds your skeleton like 500 years from now, they'll know if you're right-handed or left-handed because there's going to be a remodeling change in your spine. So you know. Anyway, it's interesting. If you want to know more about this, there's a really, I think it's awesome. It's called Anatomy Trains. Okay, and anatomytrains.com, and they do all kinds of things. The guy who created this concept of the anatomy trains, his name is Tom Myers, and he's a Rolfer. I don't know if you know what Rolfing is. Have you heard of Rolfing? Okay, so he's a Rolfer. He was actually one of Ida Rolf's students.
Wow.
And he talks about, you know, all this stuff, and there are some nice courses, and they're not that expensive. You know, he has full body dissection courses. I just finished watching one this weekend. It was all about proprioception. So the really awesome thing about this one was, you know, he was dissecting, and he and the master dissector, one of the best dissectors. I love human anatomy, by the way. I just love doing it.
We're honored.
Yeah. So go there. You know, they do these online, you know, dissection courses. They just did one last weekend, and you might be able to even ask, hey, please, can we have access to it? You know, because because of the cadaver, you know, donor program, all that, there's like some restriction. It's not available all the time.
It's not Julian Baker, is it? The dissector?
No. Okay. This guy's called, what's his name? Todd Garcia. Okay. So anyway, so basically the whole premise, or what he did with this particular weekend, was proprioception. Okay. So they dissected the hand and the arm, and then they went to the eye. And then they dissected the foot and the leg, and then they went to the ear, you know, because, you know, with your balance and all that, you know, this and this are really, so it's so interesting. I mean, I can go on and on and on about this. I'm just like, you know, this is just, anyway. So here's some reading for you guys if you're looking for more on this. Anatomy Trains by Tom Myers.
Awesome.
All right, so myofascial meridians for manual movement in therapists. And let me show you something that's going to blow your mind. Okay, so he talks about myofascial planes, all right? And these myofascial planes are just functional planes along the body. And there are several ones, but I think the one that is of most interest to us is something called the deep front line. Okay, so I'm going to just pull out, let me see if I can find it, the deep front line. And basically the deep front line, these fascial lines are function lines. So we're not just like looking at a bicep or a masseter or whatever, we're looking at function along these myofascial lines. But I'm going to show you this image. This is the image of the deep front line. I don't know if this is going to come up well on this thing, but look at this. Okay, so everything's in blue that you see here is functionally connected. So look at our world up here.
All the way.
Mastication, all these good things, neck muscles, all that, into the iliopsoas muscles, into the adductor muscles, into the flexor digitorum muscles, you know, all that stuff.
Oh,
so,
wow.
So, I mean, it's just a very interesting way of looking at the human body. Another one of the things that I do, actually, what COVID enabled me to do was to further my yoga studies, and I did a lot of coursework on yoga therapy. Okay, so part of how a yoga therapist, or in the Ayurveda or the yogic traditions, how they would deal with someone with an issue with the TMJs, is actually to work on their hips. So work on the iliopsoas muscle, and that kind of ties into this, you know.
Wow.
Because a lot of the issues that we have stored in our bodies that precipitate the TMJ issue are actually stored in our hips, you know, our emotions and our the BS that we have to deal with, you know.
Exactly.
That's just whether it's inherited or it's, you know, anyway. So one of the ways to release that is to do a iliopsoas release to help everything, you know, because the stress here isn't just localized here, it's actually in the entire body.
And that's the beauty of multidisciplinary approach of, you know, a dentist getting a patient with TMJ issues and asking, you know, have you ever been anywhere else? Maybe this other professional can see something that I'm not seeing. You know, if we treat the patient together, my goodness, we're going to get so much farther. Dr. Martha said, define hyperkyphosis for the rest of us, please.
Okay, so let me see. So when you're born, all of us are born with a C-shaped curve. Our spine is C-shaped, okay? You're like, you know, how cuddly babies are, okay? So when you start to lift your head, that's when your cervical lordosis is formed. So you start to, lordosis is like that forward bend, okay? And then when you start to crawl and walk, that's when your lumbar lordosis is formed. Okay, so you don't have a straight spine unless it's pathologic. Okay, the normal natural posture, you know, or natural spinal alignment is a gentle forward bend in the cervical spine, a gentle backwards bend, like kyphosis of the thoracic spine, and then a gentle lordosis and forward bend or curve of the lumbar spine, and then the sacral coccygeal spine kind of like curves backwards, just like our butts, you know. So that's our normal alignment. And if we are excessively curved in one direction, like if we have a excessive curvature of the thoracic spine, then that's a hyperkyphosis. Okay. All right. So there are several phenotypes for human alignment for the cervical, for the spinal alignment. You know, we've got the natural posture or the ideal posture, neutral, okay, which is what I just described right now. We have the kyphosis lordosis posture, which is the one I showed with your head forward, your shoulders rolled in, your thoracic spine curved, and then a lot of tension in your lower back because it's excessively curved forward. Okay, so that's the kyphosis lordosis. You can get a military spine, so people who are always straight, whether it be, you know, whether they are in the military or, you know, short people who try to overcompensate, you know, that kind of thing, you know. So the loss of those curvatures can occur, you know.
Look,
and then
if I stand normally, comfortable, that is
look at you.
It's awful. I have all the issues. I am the airway patient from when I was born. It's awful, but we'll get there. We'll start in some treatment. So
well, anyway, so I mean, check out this Anatomy Trains website, because in addition to the sections, they offer courses on body reading. So if you walk into my house right now, I can tell what's going on with you. Like if you stand, for example, I do some postural reads for people sometimes, and I have them march in place and then they stand, and you know, if your feet go out like this, then I ask you, were you a dancer, you know, when you were a child? And most of the time that's right. And they're like, they freak out, you know, because, you know, if you're like, if you grow up always thinking about your turnout, you know, even if you stopped doing it into adulthood, you're still in that turnout position because that's how you've developed, you know.
Wow.
Anyway,
Disney World is pretty tempting to come to Orlando, but I would come just so I can walk in your house and you can tell me what's wrong with my mom.
Well, you know, it's a good thing and a bad thing to know this stuff, because you
cannot unsee it.
You can't unsee it. I mean, I can't go to my kids' birthday parties, like the friends' birthday parties. I just can't.
Everywhere.
You know? It's everywhere.
Everywhere.
You know?
Definitely. Anne asks, are certain CBCT machines more sensitive than others? Should a patient be told to posture their tongue in a specific way on a scan, or is that misleading? Great question, Anne.
Okay, so sensitive, I'm going to ask you to follow that up by what you mean by sensitive. Higher resolution, lower resolution, what do you mean by that? I'm going to answer the second part while you fill out the other one, okay? So now, I would tell people to be in their natural posture. You know, just actually don't bring their attention to their tongue, because they will do things with their tongue, as you know. Anyone who's tried to like fill teeth or do anything intraorally, you know, the minute you bring their attention to their tongue, their tongue's going to come straight to where you're trying to drill with a high speed.
That's so true.
Yeah. So it's, you know, here's the thing. Once again, why do you want to know? Why do you want them to hold their tongue posture in whatever position it is? Mm-hmm. You know, ask yourself why you want that. Okay. If it's because you want those airway dimensions, once again, the airway dimensions don't mean much, in my opinion. Okay. If you tell them to be in natural tongue posture, and their natural tongue posture, if you don't tell them anything and their natural tongue posture is that it's really depressed, and you find that the hyoid is really low as well, then that's telling you a story, right? It's telling you that the tongue can possibly is restricted. It's not going up to the roof of the mouth, whether it's because of a tongue tie or because of the posterior rotation of the mandible, because of a bilateral degenerative joint disease or something like that, you know. So yeah, so I would say, you know, just let them be. Just let them be. Here's the thing though. I mean, if you're really fixated on these airway measurements and you want to have a before and after, then you need to make sure that your neck posture, your head posture, and your tongue posture are the same in both. Because if you're basing the success of your treatment on these measurements, which it shouldn't be, you should be basing the success of the treatment on your patient's outcomes, you know, their reduction of symptoms and whatever. Yeah. You know, then that's where you would make sure that the head posture is the same, make sure that the tongue posture is the same, you know, and find whatever standardized position you've chosen for that. Okay, so the question popped up while I was talking, and I was, okay, by sensitive, I see it. I mean, which machine should provide the most useful clinical data to inform diagnosis and treatment? Okay, so it depends on what you're doing. It depends on what you're trying to do. If your diagnostic task is to detect a tooth fracture or a missed canal or something like that, that's very fine. And then you need to be going with the higher resolution scanners. Like I know the Carestream and the J. Merita, the Accutomo, that's the J. Merita. They have those smaller fields of view, the higher resolution scans that tend to be really ideal for the evaluation of these very fine structures. Okay. And you'd have to image them as, once again, it's, you know, high resolution, so small voxel sizes and all that. But if what you're trying to do is something more comprehensive, like you're trying to figure out what's going on with the patient's morphology, whether that patient is a TMJ airway or orthodontic patient, then you do need a larger field of view. Okay. And at that point, you know, you would have to make a decision, and then the decision to acquire a cone beam CT isn't just based upon the field of view, but rather many other things. Like, for example, what's your population? Who are these people that are coming into your office? You know, do you live in Atlanta or, you know, somewhere in the South where everyone's like 200 pounds and more, you know, no, except for Renata, maybe, you know. You know, but what I'm trying to say is, like, the actual machine, like if you've ever seen these cone beam CT machines, they're like a pano machine, and there are two components that spin around, you know. So if your patient population is like a heavier population, then you need to be aware that this thing might not clear their shoulders. You know, you have to find the right machine for your practice. I'm just giving an example. There are so many other examples, you know.
Definitely.
Yeah. So, yeah. If you're asking me which machine to buy, I'm not giving you that information. Yeah, I make a lot of enemies, and then again, I mean, here's what I really believe. Okay, and I really do believe this, is that a cone beam CT unit is like a car. Okay, there are Ferraris out there, you know, and there are Hondas for sure, you know. But if you give me a Ferrari, like me, Dania, who is barely driving, you know, then I want to know how to drive the thing. You know, you know, it'll go like, you know, as I shift from first to second and all that. So it's not about the machine itself. I think it's more about the education of the person that is pushing the button, that's acquiring the image. It's not just like anyone who, you know, your dental assistant who walks, you know, who's had practically very little education, no training, you know. Yeah. You'd have to have someone who is dedicated to the operation of this machine, so that they know how to acquire the Ferrari-like images from the Honda. You know?
Definitely. I mean, being a hygienist for so many years, I remember getting some x-rays from other places that I would be like, oh my Lord, like, how did you even get an image like this? Yes. It is awful, because you're exposing the patient. It should be taken very seriously. And that is a great tip of having somebody in the office who's responsible for doing that, somebody that you do give the extra training to, that can make sure that whenever you take one image, you're going to take a really good image, a really amazing image.
Do it right the first time. Yeah, do it right the first time, and make sure there's no motion or anything like that. You know, if you've got a kid, if your practice is scanning kids, then you have to do everything to keep them from moving. You know, other than the distractions and all that stuff, but also, you know, kids that are tiny human beings, you know, and most of them can't bring their feet to the ground when they're sitting on the seat, you know, so they're going to be wiggling their, you know, they're going to be like going like this with their feet, right? And that's going to change, that's going to create motion. So, hey, one little tip here, just get a little step thing, you know, the Reebok step that's in your that's in your attic that you haven't used since the 80s, you know, or 90s, okay? Just bring that, put that underneath their feet, and you know, to keep them from moving. That's just one.
Grab a little ball.
Yeah.
Get a little ball, put in between their knees. They have to hold that ball, can't move.
Yep, exactly. Things like that.
Very good. Yes. We talked about airway volume a little bit, dimensions, and most patients who start this airway journey usually go get a Cbct first and a sleep study, and then we're looking at airway volume. Is there you already said that's not about the number. Yes. But is there kind of a range that we should be looking at?
What makes sense here? The thing that makes sense is that a smaller airway is going to have a higher risk of collapse, or, you know, more resistance, right? Okay, so it's like, you know, it's like, okay, so if I give you a smoothie straw and I give you a coffee stirrer, you know, the plastic ones with a hole, and I tell you breathe through these two, which one's going to be the easier one for you to breathe through?
So true.
You know, you've got the friction of the air particles, you know, molecules or whatever, you know, just going through, and they're creating friction against that wall, you know. So the smaller it is, the harder it is for you to draw the breath in.
And usually, whenever you're looking at a patient for orthodontic surgery, is there a way that we can grow that airway? Or whenever you look at the airway volume and say, no, I'm sorry, there's nothing we can do, that is surgery. I'm not sure if that's a decision that you usually are making whenever you see these.
I don't make these decisions. I mean, I diagnose patients. I don't cut people open. I don't treat. I don't have. I don't see many people, actually. I work from home. Okay, this is actually my home office right here, and my husband works in, I don't know if you can see the monitor behind me, but yeah. So he's the only other person I see, and including my kids. And then when I travel, of course, I see people. But yeah. So what I'm trying to say is I'm not exposed to the decision of treatment planning, you know, or
Perfect.
even the execution of the treatment. I'll give the diagnosis. I have my opinion, of course. If someone wants to ask, I'll give it. But you know, most of the time they don't want to hear what a radiologist has to say.
I actually have a great friend that lives really close to me. She's a Brazilian dentist, and that's all she did. She moved to the United States for her husband's job. She lives right here in Bluffton, and that's what she did. She would get these 3D images, and she would break them down and send it to the dentist exactly what they needed, mainly for implants, I think is what she was doing. So she has looked at some of our images that we have taken in the office and trying to explain to me. I love it. It is fantastic. I know that you have written a book called Specialty Imaging Temporomandibular Joint. How does the TMJ condition tie into the airway condition?
Oh, okay, that's fun. All right, so I'm going to do a little bragging. Ta-da! Oops, that's ta-da! Okay. All right, so this
beautiful.
Is one of them. You know, that's the TMJ book. And there's also a couple of others, but since you asked about TMJ, all right, so there are two ways, at least, or more actually. There's so many different ways that the two tie in. One easy thing to just think of right now is that if another one of the protective mechanisms that you have, if you have a small airway, is to move your mandible forward. Okay, so a kid might present like this, you know, edge to edge, you know, and then the back teeth don't touch. And after a while, their back teeth will super erupt. Okay, so there's going to be a change in the curve of SPE. You know, there's going to be a change in the condylar position, because when you move your mandible forward, you're no longer engaging the condyle and the fossa. It's actually forward like that. Okay, wow. So the patient is in maximum intercuspation, but the condyle is here. So after a while, what tends to happen is this condyle creeps back into the fossa, and there's like a rocking of the mandible backwards and an opening of the bite anteriorly. And that's just one of the ways that this is called a dual bite. Okay, so that's just one of the ways that these two are linked to one another. The airway precipitated the malocclusion, you know, and then with the condylar, like I said, seeding, later on in life, there's that bite opening up anteriorly. You know, that's just one of the ways. Another way is with condylar height loss. So if a patient has idiopathic condylar resorption, has juvenile idiopathic arthritis, has bilateral condylar fractures, anything that will minimize or reduce, the size of the condyles, then just pretend that this is the mandible right here and this is the condyle. Okay, so with the condylar height loss and the subsequent seeding of the condyle, there's going to be an opening of the bite anteriorly, just like the process that we just talked about. But with this also comes the repositioning of the tongue, because of the posterior rotation. The mandible and the hyoid and the tongue, they're all connected to one another. I don't need to tell you this. I know that you know this better than I do.
No, but we like to hear, because we never know who's listening. So please. Yeah.
All right. So without posterior rotation of the mandible, now you have the tongue falling back into the airway and the hyoid also becoming more lower in the neck. So that's another way that the two are related. So condyle started that process, or you can also have it the other way, where you are where a person has nasal congestion, large adenoids, can't breathe in and out through their noses, and they assume an open mouth posture. So all the time. So what's going to start happening is the super eruption of the teeth. Okay, and because the tongue is no longer molding the palate, it's no longer pressing against the alveolar processes on the insides, the buccinator muscle is going to push inward. Okay, so super eruption of the posterior teeth, and then this going on. So now we have an anterior open bite, and the reason would have been nasal obstruction. Okay, and then the patient is functioning in this thing, so there could be subsequent breakdown of the TMJ disc and condyle and whatnot. So just a couple of things, they're
That is so interesting how
there's more,
one issue can.
It's all connected. I mean, you can't diagnose. I tell people, I mean, if you're trying to diagnose a TMJ issue radiographically with just a scan of the TMJs, you're doing yourself and the patient a disservice because you're missing the big picture. You need to see how this manifests in the rest of the face, as well as the rest of the craniofacial complex, because there are other things that also can show up with that. Anyway, yeah.
Definitely. I told everybody that we had a special host today to join us, and we got a little bit of a conflict. She just joined. She's trying to connect her camera and her mic. If she's able to do it, I'll bring her in. But anyways, let's go to our next question. Let me see. Dr. Martha said exactly no such thing as one thing. And she loves your textbook.
Thank you.
Anne asked if you happen to have a sample scan that you can walk us through.
Yeah. I'll do that in a second. How about that?
Perfect.
Do you want me to do it now, or do you want to wait until Dr. Smiley comes on board?
We'll wait. We'll see if she can connect. I saw she connected her mic but not her camera. When looking at the nasal passage or asymmetry of the turbinates, how do we know that is in fact chronic obstruction rather than cycling of the nose?
Okay, so you need to breathe, right? Okay, and you need to humidify the breath, and you need to temperature control it and all that stuff at the same time, all right? And you can't do it at both sides at the same time, or else you're not going to be able to breathe. It's either, you have to have one side that's doing one job, which is the inhalation, exhalation, and the other one is going to do the filtration and all that stuff, okay? So it's cycling because it's going from one side to the other, all right? When you have a nasal congestion, when you're sick, it's all over the place. It's not going to be preferential to one side or the other. Okay. So that's one thing. You'll see that all the turbinates on one side are enlarged. And then that nasal cycle process, one side is going to be all enlarged and the other side is going to be all shrunken. And then if you image, I'm not telling you to image the patient like 4 hours later, but if you do, you'll notice that, or you can even look, or notice it in yourselves, when you wake up in the morning, one side of your nose is clogged up, and then you go through your life and you notice that the other side gets clogged up. It's just, with what's it called? Congestion, it's all over, Yeah. It's going to affect everything. It's going to affect the turbinates. It may affect the sinuses. It may affect just the maxillary sinuses. It can be pansinusitis, affecting all the sinuses, So.
Definitely. Whenever we are evaluating a patient for myofunctional therapy, we have a mirror. I have it right here. This one is I get from Brazil that we put underneath the nose to see which nostril is more effective and how the patient is breathing.
Okay.
But how do I know if it's nasal cycling? Because it might show me that it's one side whenever I'm checking, but it might switch. It's one of the things that we don't think about as we're checking these things.
Trust. Right? What are the symptoms? What are the symptoms,
Exactly. Exactly. Dr. Martha said C1 and ankle are connected. And I see our guest host. You guys, welcome. Hello, hello.
Hi,
Hey, how are you?
Hi, Doctor. I'm doing very good. Thank you so much for having me even for a few minutes. I'm so excited to have Dr. Dania here.
Hey, it's nice to meet you.
So, guys, Dr.
Smiley, everybody.
She's a busy lady, and she was teaching another course, so we're glad to have her for a little bit. Dr. Smiley is an airway dentist in Boulder, Colorado, who focuses her practice on implant dentistry, TMJ disorder, and pain management. So thank you so much for joining us, Dr. Smiley.
Thank you so much for having me. Renata and I talked a lot about, how amazing it is to have you here, because I'm one of your avid users of beam readers and know you guys as a style. And one of the things that I really would like to point out here is how clinically relevant our radiologists are at beam readers. And Dr. Dania, it's just your webinars, wealth of knowledge, pointing out a lot of things that clinically helps us be better clinicians. So thank you.
Oh, thank you.
Amazing job you guys are doing.
Thank you for the shout out. That's nice to hear. You know, we don't get to hear this much, so that's really nice to hear. We're like the underdogs of dentistry, you know. We work in the shadows to make you look good. That's
yes,
for sure.
That is for sure. And that, as Renata and I were putting the questionnaires together, the few things that I really I was excited to be a part of this, and I'm glad to catch the last few minutes, is what we do understand is when we're looking at our x-rays and CBCTs, for clinicians to know, from perspective of a radiologist, what are the effects of the disease and the disease processes on the bone? Because when we know and understand that, then we can take that piece and clinically become an investigator to find that out. Mm-hmm. So those questions that I know that Renata covered are pointing out to the things that we know body is doing to compensate for what is not working. Mm-hmm. And compiling that and list of the bullet points that we can take home and make it our working diagnosis process is essential. It took me a few years, and Dr. Cortez, I heard her name on the audience. We know from her perspective, long conversations I've had with her, patients come in with a bag of symptoms. And as much as we would love to see the zebras, we see the zebras because we only know zebras. But knowing that you're looking at the symptom deviation, that doesn't necessarily mean they can't breathe. Do you have another finding in the x-ray that you can combine with that? Now, on the same site the septum is deviated, if they have a jaw that is popped out and you look at the position of the condyle, how to actually identify that? Not that we are using CT for disposition of the disc, but knowing the condyle is not where it should be tells you that this is a functional problem, not a trauma problem. This is a habitual thing that has positioned things where they don't belong. And that's why we need to come together, radiologist, an ENT physician, airway physician, TMG like myself, and put our knowledge together and thinking, what is really the most likely diagnosis and a mostly culprit? So we could clear that leak, as I said, before we start mopping the floors, for lack of a better term, because that would we're becoming the better liaison for that patient. And I think in the heart and the root of it is the radiologists that can tell us, you know, these are the footprints of the disease, you know, looking at it. So I'm not sure how many of the questions we've covered, Renata, but one of the last ones we thought of was, what are the bullet points that we can just say, if you're looking for those 3 or 4 things, what would you be able to say? This patient has a sleep breathing disorder that is causing the temporomandibular joint dysfunction, and then looking and seeing what are the teeth response to that, what is the neck response to that, to put the picture together. This is really going to be helpful for the audience, and I know it was for me, because when I see that, I can't unsee it. It's like, wow, that's a big puzzle. It's nice to put it together.
And I think I did cover this. Did I just do it? Yeah, we just did it. Yeah. Sorry. We could have a private audience later on if you'd like, because I don't want to repeat myself, again with everyone else, but it's like you said, it's all connected and it's all biomechanically linked. And to look at one thing and ignore the others is, even if you're just putting implants in, you're not putting an implant in, you're replacing a functioning unit in a biomechanical structure, So you have to make sure that biomechanical structure is intact and is functioning properly, not just look for bone to put this metal screw in, right? So so that's
Dr. Bahar, you were telling me about the shape of the body of the mandible and the CBCT. Would you ask that question?
Yes.
Thank you.
Yes, actually, ironically, on Monday, that Renata asked me to join, or Tuesday, I was watching your webinar from July, and one of the things that you mentioned was just the body of the mandible as you're going through the axial view. Like if the roundable on that side is round, then you go into the condyle and noticing what is the condyle response and how the body of the mandible was shaped that way. Because we know as our faces grow during the...
Oh, we're losing her. Am I the only one that's losing her? So the question is, when can the shape of the body of mandible tell us on a CBCT?
Position of us, so the teeth never touch.
Yeah. I'm sorry, Dr. Bahar. I'm just going to answer the question. Because of she's gone, unfortunately. But like I said, there are clues in the bones, and it's not just the mandible; it's the maxilla, it's the skull base, it's all these things. You have to look at everything. Your bones are alive, and I'm going to go as far to say they are fluid. Okay, they're not liquid; they are fluid. Okay, meaning that
Wow.
the bone that you and I, when we hold a skull in our hands, a dry skull in our hands, that's not what the bone is like in life. It looks hard, but it's so full of fluid, whether it's the bone marrow spaces, the fat, and the just the circulation and all that stuff, so it's actually very spongy. And if you've ever held, and I actually did it like a 40-hour course in cranial osteopathy a couple of months ago, and they had all the different pieces of bone, all the different skull bones, disarticulated, and I held an ethmoid in my hand. The ethmoid is like up here, okay?
Wow.
And the ethmoid is as light as a feather, not even a feather.
Wow.
It's like this friable, delicate structure, So how can we, in our minds think that this thing can stay static and not respond to the function? We are functioning on these structures every day, through our occlusion, through our mastication, through our motion. Look at my head's moving, my eyes are moving, all that stuff, all that is coming together to create the function, to make me able to speak to you. And get my point across. I'm Middle Eastern, so I tend to talk with my hands too. That's my my proprioception as well,
Yep.
So anyway, so what I'm trying to say is the bone is going to respond to function, and the mandible has clues in it as well to how, when you're functioning on your mandible in a certain way, or if one condyle is smaller than the other, that the forces that are transmitted through to the bone from the muscles of mastication with that smaller condyle, that's going to remodel and change the shape of the bone. So sometimes the clue to if there is a condylar hypoplasia isn't the shape of the condyle itself or the size of the condyle itself, it's what's doing to the rest of the mandible. I mean, that's just an example. Let's not even talk about what it does to the maxilla, what it does to the septal deviation, as you mentioned, to what it does to the skull base and the whole mechanism of gears between all the bones of the skull, anyway.
Definitely.
So that's, that's just something that I covered some of the stuff in my own courses. I do these, I like to teach not in bits and pieces, but I teach holistically. I teach if it's a TMJ topic, it's not just about the TMJs, it's about what it's doing to the face, to the growth of the face, to the occlusion, to the to the head posture and that sort of thing, and how it manifests as airway issues, and then going through the airway from the tip of the nose down to the hyoid. So I mean, if you want to know more,
Right, exactly, we'll get there.
Yeah.
Dr. Cortez said there's a program, posturology, where even the SI joint is important to the pelvis and head, skull, and most important affects the TMJ joint.
Of course. I mean, if you, in that cranial osteopathy course, I thought that it was going to be all about the head. And guess what? It wasn't.
Wow.
It was about the head and it was about the sacrum. Okay, so actually there was some stuff that we did with the head, but we also have to learn about the sacrum. And when you think about the connections, and once again, it goes back to fascia and understanding the role of fascia in our systems, the encasing, the meninges, the thing that covers the inside of our skull, and and the dura and all that stuff. That dura is continuous, all the way down around your brainstem, all the way down your spinal cord, all the way down to your sacrum. Okay, so for cranial osteopathy, if you're going to be doing anything to help the TMJs, one of the adjustments you have to do is actually the sacral adjustment. Okay, so they would slide their finger, and I don't recommend any dentist do this because you'll get sued faster than you can say sued. All right. You slide your hand underneath somebody's butt, underneath their sacrum, and adjust it. But do not do this in your dental office. Okay, send it to someone who knows what they're doing. Okay.
Believe it or not, actually, in my last, seminar that I was attending, this was the question I literally answered. What would a dentist do for someone that came in with a low back pain? Mm-hmm. And to me is, well, again, piece of puzzle. If they're not breathing, their head's here. We know that C2 and L4 rotate together. And we're looking at the X-ray and we're seeing that kyphotic position. That's going to cause that lumbar curvature. And once we clear the nose, clear the jaw, is this better? And I've seen that happen without touching their lumbar. I've taken lumbar pain away because really this 12-pound medicine ball decided the fate of the rest of the kinetic chain. And there is so much on the craniofacial X-ray we could see and observe how body is just having all these descending issues that's telltale of the posture changes. Posture is very sensitive to function of the nose and airway. And if we don't take that into consideration, the whole while we're straightening up the posture without knowing what's causing it to begin with. So that was just an interesting comment you made, because I literally just get off the phone and I was just doing exactly the same conversation, same group.
Part of what, and I hope that you'll go back and listen to the recording, because I did talk about body reading, and this helps you understand that also with a little bit more. And I also spoke about this dissection course that I did over the weekend, where they dissected the eyes and the hands together, and then the ears and the feet together. Okay, and then they flipped the cadaver over and looked at the suboccipital muscles and all that, and correlated how the systems of the ocular motor muscles are very similar in arrangement. The things that move the globes, the circles, the balls of the eyes are very similar to the things that move the ball of the head. Just the arrangement and all that. So, and when you descend and you go into like the actual dissection of the hands and the feet, I've watched several of these, but they're just seeing it in that perspective rather than bits and pieces. And this is the heart, and this is the lung, and this is the what. No, let's look at it as a continuum. So anyway.
Definitely. Well, Dr. Dania, you've written 3 amazing books that we spoke about earlier. We have been translated in multiple languages. Your 3 babies, right? Other than your own children. Please let our viewers know about these amazing books. What are the other 2 that you didn't talk about?
Hold on, let me pull them out here. I mean, wretched is a dog that doesn't wag its own tail, right? Okay, so here. Specialty Imaging Dental Implants. So that's one. And then there's a TMJ book that I just showed you. This is actually coming in. This is coming into second edition. I'm actually working on the second edition of this, but it's going to be called Specialty Imaging Temporomandibular Joint and Sleep Disordered Breathing, just to talk more about the globality of the issue. It's not just about looking at the TMJs. So that should be coming out in a couple of years. And then there's this one, which is Diagnostic Imaging Oral and Maxillofacial, and this is now in second edition. It's going to go into third edition after I finish the TMJ book. So.
Yay! That is amazing.
And that was my workout for today.
How about your courses coming up?
Oh,
Who can sign up for them?
I actually have a course coming up next weekend. I don't know if anyone is available. Yeah. So basically, the way that I hold these courses is that they're not a full day sitting on our butts in front of the computer screen, because that's painful to everyone. Okay. They're virtual. All right. What I do, because I am also cognizant that a lot of us have kids and have lives, and it's not healthy also to sit in front of the computer screen that long. So what I do is on next Friday in the morning, we're doing 4.5 hours. It's the whole course is a TMJ Airway course. Okay, so 4.5 hours in the morning, and then the next one is going to be on the Sunday. So I'm going to give you Saturday to digest the information, okay, that we collected on Friday morning, and then Sunday morning is where we complete the circle, and there are going to be some cases there. They're going to be, of course, I'm going to go through a lot of the stuff that Dr. Ismaili just asked, the morphology and that kind of thing, facial growth and how the TMJs affect that. Talk about its relationship to occlusion. I'll talk about the MRI evaluation of the TMJs, internal derangement, just helping people understand the TMJ, okay? And it's basically starting from the soft tissue changes of the TMJ, going into the hard tissues of the TMJ, and then the hard tissues of the facial skeleton, and the changes in the neck, and the changes in all that stuff. So yeah, so that's it. And it's coming up, like I said, it's next weekend, and you can find the information on beamreaders.com. So if you go to beamreaders.com/courses, I have 2 courses coming up. There's this one that's coming up right now, and then one in the fall That's on how to read a cone beam CT. So that's a deep dive into anatomy, like a deep, deep dive into anatomy, the skull base, the cervical spine, the nasal cavity, all that stuff, you know, maxillomandible, obviously. But once again, in a more holistic view. Okay, so we're not looking at bits and pieces. We're looking at it as a continuum, as a living structure, and bones that are responding to life, you know, as opposed to just like being there, you know.
So are these courses only for dentists?
You can attend if you're not a dentist, if you feel like you can stomach the information, for sure. Yeah.
Perfect.
It's, you know, it's for, I speak simply. I don't know if you've noticed this or not. I tend to speak very simply so that any person can attend and understand, because I think that this is something that's important for people to understand, you know, and the dental profession in general, you know, regardless of how specialized you are. If you're just out of dental school, I give some of these courses to actual dental students, you know. Pre-dent, I've given a couple of courses as well, talking about the basics, you know, understanding that we're not just drilling teeth, you know, we're not tooth doctors, you know, we're not aligners, we are doctors, we are physicians of the oral and maxillofacial complex, and we should treat ourselves as such and be respected as such. But we're not going to be respected as such unless we take the initiative and respect ourselves and gain that information to start with and understand it. And that's what I'm trying to do with my, you know, my professional career, help people understand the system. Because it's complex, it's hard. I mean, the TMJ, no one taught me the TMJ until I met David Hatcher. You know, I was like in dental school, you know, they don't really teach it that well. So I try to break it down, make it simple.
Perfect.
Yeah.
I will post the website and how to sign up on our Facebook group, on our Circle Facebook group. Whoever's watching this, if you guys are not following us yet, please, we're on Instagram and Facebook. We have meetings, 5 meetings a week. Right now, most of them are on Clubhouse. We have Tuesdays and Thursdays at 8 p.m. Eastern Standard Time. Dr. Martha hosts a Clubhouse room at 5:55 p.m. Eastern Standard Time on Wednesdays. And on Sundays, we have Dr. Jasmine Elmore, who hosts a room at 1:30 p.m. And then on Fridays, we have these beautiful, amazing lines with incredible speakers. I am so appreciative of your time and your knowledge, both of you, for being here. Thank you so much for sharing this whole hour with us.
Thank you.
Anybody has any last word?
No, keep on learning, you know. It's a
I just want to add something to Dr. Dania. I just was so appreciative of you saying we need to hold our profession. Dentists are physicians of the head and neck. Amen. We are physicians of the head and neck, and the more we get distracted by teeth and straight teeth, white teeth, the less of the body attached to that we see. And bringing the attention back to the body that is in charge of those teeth, I think that is on us, the ones with the DDS.
Absolutely. We need to lose the tunnel vision.
Yes.
You know, we all have the tunnel vision. All of us in the dental profession,
Yep.
We're all looking at people's class 3 caries, you know, and can't keep our eyes off of it. You know, we're all looking at their malocclusions. We can't help it. You know, we need to tear our eyes away from that and start to look at why is that malocclusion occurring.
Exactly. You know? Understanding the contact of the teeth is exactly like contact of the vertebrae. It's then and only we know that, yes, that is exactly like being doctors being doctors.
Mm-hmm. Definitely. Well, we'll have 2 more meetings. I'm already late for the Airway Circle meeting. Yay. So guys, thank you so much. You're wonderful. And I hope that this is just the first of many opportunities for collaboration for all of us. So thank you.
All right.
Have a wonderful
Take care.
Bye-bye.
All right. Have a good weekend.
You too.